If anyone's having trouble hearing us, please give a signal. But welcome to everyone in our Mountain West ATC Echo family. Happy to see you all. Welcome to the team gathering here. And today what I thought I'd do is an update on dual or two-drug antiretroviral therapy. We haven't done a formal update on this in a while, and there have been a couple recent publications. I'm going to go ahead and talk about two-drug ART, both for initial antiretroviral therapy and for maintenance therapy. First, we've talked about this, but why do we even study and care and think about using two drugs and we know three are effective? There are certainly potential advantages such as reducing side effects, potentially reserving future options, and a big one that's talked about is potential cost saving. And I won't go through all this data, we've talked about it, but this is a very nice modeling study that outlines some of the huge potential cost savings if two-drug therapy for initial or maintenance treatment is confirmed to be effective. So I'll refer you to that if you want to see more. One thing I am not going to review today because Dr. Spock did a fantastic review of it is the data and indications and details for the FDA-approved two-drug option of dolutegravir rilpivirine, which has the trade name Juluca. So David's talk goes through all the details and is definitely worth watching, especially if you missed it or worth reviewing. It's on our website, and you can find that on November 30th, 2017, and there is the website. So this is the only really FDA-approved two-drug option, dolutegravir rilpivirine. You can see here a review of the indications, really only approved for maintenance therapy, so for switching select suppressed patients, and you can see there the criteria that are in the FDA indication. So the only FDA-approved option, dolutegravir rilpivirine, approved for maintenance therapy. That is a review of the indications and criteria, and please see Dr. Spock's presentation for more detail. Here is what I am going to talk about, the starred studies here. So this is not a complete list. This is my select list of the studies I'm most interested in, I think are most relevant for clinical practice for two-drug ART. On the left in the blue, studies of two-drug antiretroviral therapy for initial treatment, for treatment-naive patients. So the ACTG 5353 study is now published. I'm going to review that. So that's dolutegravir plus 3TC or lamivudine for first-line therapy. Boosted darunavir, lamivudine, we talked about this once, was presented at IAS, and I am going to review that. We have not seen data yet, or at least as far as I'm aware, there's not data yet for this study of boosted darunavir rilpivirine two-drug initial therapy, but I do think that is forthcoming. So for initial two-drug ART, I will talk about these two starred studies here. There are many more trials going on for two-drug maintenance. The ones I'm going to highlight today are a recently published study of dolutegravir lamivudine or 3TC for maintenance therapy and boosted darunavir 3TC or lamivudine also for maintenance therapy. Again, not a comprehensive list, but these are the ones that I think are most relevant to clinical practice. Let's start with two-drug therapy right up front. First regimen for treatment-naive patients. So this study led by Babafemi Taiwo from Northwestern was just published in CID. It was also presented at IAS in Paris. This is ACTG 5353, dolutegravir plus lamivudine for initial ART. So this is a phase 2 single-arm pilot study looking at the virologic efficacy of starting treatment-naive patients on dolutegravir plus 3TC. There was a much smaller pilot study called PADDLE done in Argentina, which intended to enroll treatment-naive people with viral load below 100,000. A couple people snuck in and had pre-treatment viral load just above 100,000, but gave them all two-drug initial therapy with dolutegravir 3TC and had very, very positive results. So this current ACTG pilot study is building on that. Here, they enrolled treatment-naive adults with an HIV RNA or viral load above 1,000 copies, but below 500,000, so could not have a baseline viral load above 500,000. They did intentionally try to get at least a quarter of the participants who had a baseline viral load above 100,000. So they actually did allow above 100,000 and wanted to have at least a quarter of the participants with a baseline viral load above 100K. The participants in this trial could not have evidence of NRTI, integrase, or major PI resistance mutations, and they did do baseline integrase genotypes on everyone. So not necessarily standard of practice, but they did do that. Individuals could not have chronic Hep B because, as we've talked about, this would not be an adequate regimen for HIV Hep B co-infection. But they ended up with 120 treatment-naive individuals starting dolutegravir 3TC dual therapy as their first regimen. Here are the characteristics, and it's a single-arm study, so the two columns here are simply those participants with baseline viral load above 100,000, and you can see here N of 37, so they did achieve their goal of getting more than 25% with baseline viral load above 100,000 compared to those with baseline viral load below 100,000. And you can see here about, I think it was 38% of the individuals in this arm had viral load above 200,000, so a few folks with what we would consider relatively high viral loads, but again, you could not have a viral load above 500,000. So that eliminated people from this trial. But here's the punchline, and I'm going to pause on this for a moment because I think there's one point that's very interesting. So when we look at all comers, and this is at 24 weeks, all comers who started dolutegravir 3TC as first-line therapy, 90% had a suppressed viral load at 24 weeks. When we look between those who had baseline viral load below 100K and above 100K, there was not a dramatic difference. But this point at the bottom I want to highlight. There were 3 individuals who had virologic failure. They also had low to undetectable dolutegravir levels, so they clearly were not adhering well and were missing doses and not taking their therapy. But one of these individuals who started therapy with dolutegravir 3TC did develop emergent integrase resistance with an R263K, which is a signature dolutegravir failure mutation. It's rare. It doesn't actually affect dolutegravir activity that much, but this is something we did not see in the treatment-naive trials of dolutegravir plus 2 NRTIs. And similarly, we did not see in the treatment-naive trials of bictegravir 2 NRTIs. This is only one person, but I pose this question, how significant is this? Is this a signal that 2-drug therapy right up front is not enough and we really should be using dolutegravir with 2 NRTIs for treatment-naive therapy, or is this really just an anomaly? I don't think we know, and I think we need to know more. But this catches my attention because, as we've talked about, starting people up front with dolutegravir plus 2 NRTIs, even if they fail, they tend to do so without integrase resistance and without NRTI resistance. One person in this trial of dolutegravir 3TC, initial first-line therapy, did develop integrase and NRTI resistance. So what do we make of that? I think we need more data to know, but it does catch my attention. As far as I could tell from the presentation, it wasn't in the publication, as far as I could tell from the presentation, this person who failed with this resistance was actually in the baseline viral load below 100K group, but it was a little hard to sort that out. Switching then to one additional trial of 2-drug therapy for treatment-naive individuals. This is a study that was presented at IAS. We did talk about it once, but I'm going to review it quickly because I think it fits nicely as a comparison to the trial I just talked about. So this is the Andis Trial, a randomized open-label study done at 5 sites in Argentina in which treatment-naive adults with a baseline viral load above 1,000 copies and no NRTI or major PI resistance and no chronic Hep B, because the 2-drug therapy would not be adequate for Hep B, were randomized to either receive upfront 2-drug therapy with ritonavir-boosted darunavir plus 3TC or lamivudine versus ritonavir-boosted darunavir and more standard 2 NRTI therapy. Slight differences because this was done in Argentina and there are different formulations available there than here. The darunavir-ritonavir was actually in a combo tablet, a generic combo tablet, which we wouldn't be able to find here, and it was TDF3TC instead of TDF-FTC, but that's about the same thing. This was sort of a phase 1, and then they had some criteria. If a certain number met thresholds for efficacy, they would go on to phase 2, which they actually are doing. But what I'm showing you is the phase 1 up to 24-week data, and you can see here the baseline characteristics, which were not dramatically different. And the punchline is that as first-line therapy in this trial at 24 weeks, the combo of boosted darunavir 3TC seemed to be as effective as boosted darunavir plus more standard 2 NRTI therapy. So in this trial, upfront boosted darunavir 3TC seemed to work well. We still have relatively small numbers here. This still is definitely not standard of practice or not in guidelines, but I do think it is very interesting. The one virologic failure that occurred here was actually in the triple ART arm and did not have resistance mutations. Not surprisingly, there were fewer adverse events in those who got 2 drugs versus 3. Switching then to what I think may be more relevant, or we may start utilizing clinical practice sooner. Instead of 2 drugs up front, let's talk about maintenance therapy with 2 drugs. So this is for individuals who are on more standard therapy, are suppressed, taking their meds, and maybe have some reason that we want to avoid NRTIs or some reason to transition to 2-drug sort of NRTI light therapy, avoiding tenofovir and avoiding abacavir. So first, this study, also led by Babafemi Taiwo, is also now published in CID. So this is the ASPIRE trial. So the first study I talked about was dolutegravir plus 3TC for upfront therapy for treatment-naive individuals. This is dolutegravir plus 3TC for maintenance therapy. We had talked before about this smaller single-arm pilot study that looked at this. This is sort of a larger pilot study building data for this strategy. So they enrolled very carefully selected people, adults living with HIV, suppressed on at least 2 checks over 48 weeks, screening RNA below 20 copies, taking any 3-drug ART regimen with no history of failure, no NRTI resistance, no chronic Hep B. So this is not a strategy for just anyone. These are people who take their pills and are routinely suppressed and don't have resistance or prior failures. But for these individuals, they were randomized to either continue whatever 3-drug ART they were on or simplify to 2-drug dolutegravir 3TC as 2 pills in this trial. But we've talked about there is potential in the future that these agents are going to be combined into a combo pill similar to dolutegravir rilpivirine. You had about 45 people in either arm of this trial. These are the baseline characteristics. There were actually some differences in the baseline CD4 and CD4 nadir, but I don't think that really affects the results because they were lower in the 3-drug arm. So you'd think if these end up being equivalent, that doesn't really matter. And these are the regimens that people were switching from. You can see there was a pretty even distribution between those on NNRTIs versus boosted PIs versus integrase. The majority in this trial were switching from a TDF-based regimen. And here is the punchline. So this is virologic suppression by FDA snapshot at 24 and 48 weeks, just focusing on 48 weeks. Those individuals who were suppressed and continued 3-drug ART in the blue, and those who transitioned to dolutegravir plus 3TC really did equally well. This met criteria for non-inferiority. The one virologic failure that occurred in the dolutegravir 3TC arm did not have emergence of resistance, which I think is reassuring for this as a strategy for maintenance therapy. A very similar idea, again using transition to boosted darunavir plus 3TC, dual therapy with very similar inclusion criteria and very similar randomization, slightly higher numbers. So these are individuals taking boosted darunavir plus 2 NRTIs with routinely suppressed viral loads, randomized to either continue this more standard 3-drug boosted PI-based therapy or switch to boosted darunavir plus 3TC. These are the baseline criteria. Again, the only differences are not such that I would interpret the results any differently. Again, most switching off TDF. And again, the punchline that really the transition to boosted darunavir lamivudine dual maintenance therapy for these carefully selected individuals did seem non-inferior to continuation of standard boosted darunavir plus 2 NRTI treatment. Not surprisingly, because many people were switching off TDF, lipids did worsen slightly. We've talked about how coming off TDF may worsen lipids a bit, but renal function did tend to improve. So again, I didn't recreate all of that, but you can see more on that if you want in the publication, but I think that was not surprising. So that is my very short summary of updated data on 2-drug ART for initial and maintenance therapy. Just to summarize, the one FDA-approved 2-drug option is the combo tab dolutegravir rilpivirine, approved only for maintenance for carefully selected individuals, not approved for upfront therapy. We talked last week that a lot of us have had trouble getting insurance approval for that option thus far. I think the data for 2-drug maintenance therapy using other options like dolutegravir or boosted darunavir plus 3TC seems very promising, and I feel pretty confident that in the future those will be options, again, for carefully selected folks. I'm personally, just tell you my opinion, I'm personally struggling a little bit with the upfront therapy for the treatment-naive person, especially with a relatively high viral load. Do we really need 2-drug therapy, especially now that we have TAF? And should we really be putting resources into looking at this? I don't know the answer. That one person in the dolutegravir 3TC study who developed integrase and NRTI resistance really gives me pause. And personally, I would not be using 2-drug therapy right up front as things stand now in this country with all of our options. So the outstanding questions that crossed my mind that I sort of populated here. So what is the risk of resistance with suboptimal adherence, especially starting 2 drugs up front? I have not seen anything about the activity in the CNS and other compartments, and we don't have long-term data on risk of hand and various other long-term complications of HIV infection. Again, the treatment-naive trials do eliminate people with very high viral loads, and I personally would not be considering 2-drug ART for those folks. How really do we pick the right people for 2 drugs if we do start using it up front or even for maintenance? And I guess I'll just throw this out there. Now that we have TAF, how much do we really need these 2-drug options? And I'll just let you ponder that, and I will end there and take questions or comments.